Olá a todos, boa noite, bem-vindos ao Galen Club. Este, na verdade, é o primeiro Journal Club da plataforma Galen Academy, que faz parte de todo o ecossistema de pesquisa, educação e ensino com o Brazilian Clinical Research Institute, o BCRI. E hoje o tópico é sobre os critérios atualizados de Duke de endocardite infecciosa. E para nos juntar hoje à noite, é um prazer muito grande, eu vou apresentá-lo e a entrevista vai ser em inglês. Meu amigo Vance Fowler, que é professor de medicina também na Duke, professor de genética molecular e microbiologia genética, e também um membro do Duke Clinical Research Institute. Então, é um prazer muito grande, porque ele é o primeiro autor, na verdade, desse documento atualizado, e com toda essa experiência em microbiologia molecular, genética molecular, ele liderou esse documento de tão importância para a prática clínica e também que vai aumentar demais e viabilizar mais pesquisas nessas áreas, conforme nós vamos discutir. So, Vance, I'm really pleased to have you here in our first Galen Club, discussing such an important topic. I just introduced you as Professor of Medicine at Duke University, as well as Professor in Molecular Genetic and Microbiology, which is really fascinating and illustrates how smart you are. And we are really pleased to have you here to discuss this really important document and work that you led together with others, which is the 2023 Duke International Society of Cardiovascular Infectious Disease Criteria. So welcome, Vince.
Renato, obrigado por todas as pessoas esta noite. Esta grande oportunidade para mim discutir esta pesquisa de nossas created. Desculpa por causa eu esqueci maioria de meia português, mas esta grande oportunidade. Graças, obrigado.
I'm really impressed. I'm sure nobody was waiting for this one. I was definitely not, to learn that you speak reasonably Portuguese. So really exciting to have you here, Vince. And again, congratulations are really important. I know how difficult it is to create a consensus documents or a guideline or a guidance document, especially having to deal with different members and voting and controversial issues. It's an endless work. And when it comes to fruition, like a nice publication it's really nice to see. And I believe this paper is really important, not just from the clinical perspective, but all the clinical research arena that I think might increase or improve in this field. And I'm sure this was one of the goals of your paper that we're going to talk about. But Vince, let's get started with some history here. Because if we look at now the first time that there were criteria for endocarditis, this was 1981 with the von Rhein criteria. And after that, we get the 1994 Duke criteria to increase sensitivity, done by David Dirac. And then in 2000, our friend Jennifer Lee updated with the modified Duke criteria. And now 23 years later, you come up with a new criteria. So tell us a little bit about this history, Vince. Why it was necessary in 1981 to create these criteria? What were the issues down at that time? And why we needed to really update this at different times in terms of the updates. And now with your update, 23 years after the last update, why did we take so long for this update? So give us a little bit of your view in this history.
Sure. The bottom line is that the diagnostic criteria changed because the diagnosis and the treatment and the management of the disease changed. You know, when when Fordham von Rhine described endocarditis in 1981, you know, he identified some really fundamental strengths about how to approach the diagnosis. He broke the categories down into definite and possible and rejected, you know, probable, possible, and rejected. And that was a real strength. One of the weaknesses was that the only way you could reach the point of definite endocarditis was if by tissue. Either there had to be a valve surgery or autopsy. So that was, if you had a positive case, you were absolutely certain it was positive. But as we all know, many of the cases, at least half of the cases, don't go to valve surgery, and yet they have endocarditis as well. So that gap was really what triggered the need for the Duke criteria in 1994, because the big advance that the Duke criteria provided was the use of echocardiography and the ability to make a clinical diagnosis. In other words, if you had an echo that was consistent with endocarditis and you had positive blood cultures or what have you, you could make the diagnosis of endocarditis without having to have tissue from the patient. So then 7 or 8 years later, in 2000, when Jennifer Lee and Ralph Corey and everyone did the modified Duke criteria, you know, there were a couple of small changes, but really the single biggest change was probably not even one that was highlighted or that we recognized at the time we wrote the paper. And that was that we allowed that certain microorganisms to be so-called typical bacteria, regardless of what clinical setting they were isolated. And that was in particular for Staph aureus. So in the earlier criteria, you had to have community-acquired Staph aureus without evidence of a source, and et cetera. And in the 2000 criteria, what we really basically, the change was that, you know, Staph aureus, because it's such a problem with endocarditis, if you find it anytime, you got to worry. And that was what was reflected there. And then, you know, 15 years went by, probably longer than any of us would have expected to make but it did. And then the European Society of Cardiology developed guidelines, you know, their treatment criteria. And in that, they established a diagnostic criteria. And the thing that really they brought to the table was the use of additional imaging techniques like PET scan, cardiac CT. And then most recently, so another 8, you wind forward another 8 years, and here we are today. And what we tried to incorporate in the most recent diagnostic criteria was, you know, really two things. One, diagnostics in the area of microbiology. So, you know, things that we're doing all around, the genomics revolution, sequencing from tissue, sequencing from blood. And then two, of course, incorporating imaging. And then a few other things that we can get into. And I think I'll stop there.
Great. So really, really interesting. So different times and different technologies also probably, as you said, really guided the need for updates, correct? A change in the microorganisms, but also a change in technology, right?
Absolutely. That's exactly right, Renato.
Great. So then, Vince, and you and I were talking about this before. Every time we want to do a consensus, I don't think that there is even a worse word than a consensus, because there is something that is not a consensus, is a consensus. We know that we have members, and very difficult to reach consensus among different specialties. So, but nonetheless, we need to do our best, and there are ways to try to do that. And this time, you partner with the International Society of Cardiovascular Infectious Disease with several specialties. Tell us a little bit about this process. I mean, who were involved? How were they picked? How long did it take? I know it's forever. How many drafts, if you can remember? And how do you really solve, I mean, what seems to sometimes be unsolvable? Because the discussion goes on and on and on, but we need to make a decision. But I think it's important for the audience to know that sometimes when something's written there, it's not so straightforward. There are sometimes uncertainties around those things, and we do our best, but there is oftentimes there is really not no certainty or 100% certainty around all recommendations. So tell us a little bit about this process.
Yeah, well, Renato, you're 100% right. It sounds like you've done a couple of these so-called consensus things yourself. The goals, I think the big overarching sort of ideas were that we needed it to be as globally or geographically representative as we could. And we needed it to be as sort of diverse in terms of specialties as we could. And so that guided, the selection of individuals. We had identified folks within ISCVID or who had, published expertise in their areas, and ultimately identified folks from, I think, 5 continents. And so 25 members of the working group from roughly 5 continents and 6 different subspecialties. So cardiology, of course, infectious disease, clinical microbiology, radiology, cardiothoracic surgery, and pathology, cardiovascular pathology. And then, we just began the process of identifying who was going to sort of lead the discussions or the focus on each. And, then there was the process of trying to get it down to 3,000 words. So that was, we started the process, I guess, in probably December of 2021. I presented the idea to the ISCVID because, honestly, because I was doing studies with diagnostic companies working on the capacity to identify and diagnose culture-negative endocarditis, and was using it in my clinical practice. And yet there was no way to incorporate that technology into the diagnostic criteria. And then I started talking to people from Denmark and other places, and they were describing, fundamental shifts in our understanding of the microbiology that weren't reflected in the criteria. And I said, it's time to update it. And so it started in December of 2021, and then we finished up in, about, I guess, March of 2023. So
not too bad. I mean, a year and a half. I mean, sometimes we do trials that take 10 years to get it done.
Right. And on the scale of things, it could have been a lot worse. I think the thing that really helped was a lot of the hard work had already been done. Right. I mean, some of the fundamental concepts of the Duke criteria, major, minor, the clinical diagnosis, all that was sound. I mean, we really weren't changing or altering any of the fundamental groundwork. We were simply trying to get the groundwork into the 21st century. And that's really that's probably why one important advantage that we had.
Correct. And you have key voting members as well. Do you have statements and you ask people to vote on statements? I mean, you led all this, but that's how it worked.
It was, I mean, to some degree, yes. We worked. A lot of it depended in part on the expertise. For example, PET CTs. Some of the, that was one of the areas where there's a lot of controversy. Right. Specifically as it relates to the diagnosis in native valves versus prosthetic valves and timing. Is it going to be within 90 days? What do you do with imaging? And what about glue and the false positives that you can get? And that went around and around and around. And ultimately that's sort of where we would get sort of groups, individuals in there who had specific expertise in that field. That's where the radiologist and the imaging cardiologist and so on would come in, and we say, all right, we need a statement. We need a statement. Ideally, not more than about 8 or 10 sentences, please, not 500 sentences, and as to what you all can agree on. What is it that you feel is going to be the least bad option, and then we present it to the rest of the group, and that's how we did it. I mean, at some point you just have to make a decision too, right?
Right.
And so, and there were times when it was just like, all right, we've gone around this, let's get the expert in the group to make the best call, and it's time to move forward.
Correct.
And that was sort of my role, I guess you could say.
Correct. No, I get it. And was any opportunity for the public to vote on things? Were anything put online, or it didn't happen?
There was. There was. We developed sort of that criteria and had it available at the time of the ISCVID meeting in Barcelona in June of 2022. And I got up, and for about 2 hours, we led a vote, a discussion. We presented each of the proposed criteria. We got feedback from the attendees of the meeting. There's several hundred people there, and we took notes and we revised things. We added new people into the working group as a consequence of their attendance at the meeting, if they could bring in new additional input. So yes, there were folks voted on the recommendations, and if they were supportive of it, then we would go forward. If they rejected it, then we typically let it go. And there were some criteria that fell into each of those examples. But yes, that weekend meeting, because we presented it on Saturday to a group for a couple hours, and then we presented it again the next day. So there were 3 or 4 hours of voting, and we had it online for the people to be able to review it in more detail and provide written commentary. So it was, there was a good deal of feedback.
Correct. No, so that's really important, Vince, for people to realize how difficult it is to write something like that. And even if you get the best experts, sometimes the evidence just don't exist.
Absolutely right. Absolutely.
And then you have to make a call, and we believe it's the best for clinical application, but also from the research perspective. So really nice. So then you guys got it done, which was great. And then let's dive into some of the changes, Vince. And let me start with something that based on things that I've been hearing, people asking me about, and people that I'm been reviewing articles online and opinion pieces. It's about the classification and the diagnosis. So can you talk a little bit about the 3 possible classification of endocarditis in terms of definitive, possible, and rejected?
Yes.
If there is any major change on that or not, because I think there is a perception that maybe a positive blood culture became really, really needed for the diagnosis nowadays. And before, you could have diagnosis without that. with one major criteria plus three minors. But it seems that the structure really did not change, right, Vince?
That's absolutely right. And if it's okay, maybe I can show a couple of slides, Renato, briefly to walk through that, because I think that's
Sure.
probably an important point. So
Sure.
if
yeah, I think it's important. Let's just give Vince the ability to share the slides.
Okay. So, okay, I'm loading. There we are, sharing, and let me minimize this. So let me move forward this. All right. So the first point is that the fundamental structure is unchanged. We continue to, and because I think the fundamentals are right, we continue to identify definite, and definite can be identified either pathologic or clinical criteria, possible or rejected. So with definite criteria, the fundamental elements about the definite criteria are unchanged. It's just the details that are a little different. In the previous criteria, there was a pathologic criteria, for definite as well. There's still, we retain the pathologic definite criteria. We're just expanding the ability by which you can identify organisms. So as you see in this slide, the real change is in the red highlight, is just the way in the old days you could identify, if you identified an organism from a valve by culture, by staining. But what's been added is techniques that our pathologists are using now, like PCR, sequencing, and even a thing called in situ hybridization. So if you identify the organism with these new techniques, you have definite criteria. So that's really the difference with pathologic.
But you could have pathological criteria or clinical criteria for the definitive, right?
Absolutely right. And the definite clinical criteria should be shown in the slide here. It's unchanged.
Correct.
2 major, a major and 3 minor, or 5 minor. No change with that.
Correct. So I think that's really important, Vince, because I don't know if it was a misinterpretation or how the reading came along, but not all, but a lot of people actually, I think, understood that a major change in the definite criteria was that now the microbiology or the positive blood culture gained more strength in the updated criteria. And you are clearly stating that that's not the case. What really changed is that now, if anything, we'll be able to make and do more diagnosis because we have more advanced tools like PCR and sequencing and other things that 20 years ago we didn't have. Is that correct?
That's absolutely correct, Renato. So that there's no change in the clinical definite. If you have a vegetation and echo and blood cultures, you've got positive blood culture, you've got endocarditis. If you have vegetation and you have a prosthetic valve and you have a fever and an injection drug user, you've got definite, clinically definite endocarditis. Right. None of that's changed. And then possible endocarditis, nothing's changed. A major criteria and a minor, or 3 minor. So no change with regards to clinical definite, no change with regards to possible endocarditis.
Perfect.
Now with rejected, there are some small things that have changed, and it's really about details. One was defining what firm alternate diagnosis meant. So a lot of the changes in this paper are in the footnotes, and this is no exception. You see the little red footnote, a firm alternate diagnosis consisted of either two characteristics. And basically the new change is that we're defining what firm alternate diagnosis means. If you had microbiologic alternate diagnosis that's rejected, it's in the yellow here. You had to have an identifiable source or bloodstream infection, a non-typical pathogen, rapid resolution, and no evidence of endocarditis on imaging. If you had a non-microbiologic cause in the blue, you had to have a firm alternate non-microbiologic cause, such as, for example, morantic or non-bacterial thrombotic endocarditis, that sort of thing, Libman-Sachs, and absence of clinical evidence of endocarditis.
Correct.
So that's, and there were a couple other small changes, but that's really the big issue. I'll stop sharing there and happy to share it further if it's helpful. But the key message is no change with clinical definite, no change with possible endocarditis. Just the same as it's been since 1994.
Correct. And the pathological criteria just expanded.
Absolutely. That's exactly right, Renato. This is, just like I said before, we are not overhauling the structure.
Correct.
So this is like taking a good car, your dad's, good car that's got a good engine, but it just looks terrible on the outside, and putting a new exterior body on it so that it looks like it's a 2023 instead of a 1973.
No, that's great. Thanks, Vince, because I think that was a really, really important clarification from your view and your point of view. And along those lines, Vince, in terms of expanding the techniques in identifying different pathogens, one of the chapters or one of the sections that I thought was really interesting was the blood culture negative endocarditis, the BCNE, the BCNE. So why this is important, and is this scenario where we are more likely to have to use these extra techniques or these more advanced techniques? How would you position, like when should we, or when should some, the common clinicians in the hospitals think about using PCR or gene sequencing or other types of things to identify endocarditis, especially in the light that these techniques might not be available. As a matter of fact, they are not available all over the world, and in the same way that we might have at Duke.
Completely right. It's, I would say one thing: they're not available today. They're not available today, but 10 years from now, or 50, they probably will be a lot more available. I mean, just think about from the ID world, 10 or 15 years ago, HIV viral load was not available in most parts of the world. And now it's available in most parts of the world, have access to HIV viral load. So I totally agree that it's not a universally available, even in the United States, and it's even difficult to get at Duke. But part of this is thinking about the future. Part of this is thinking about how is the diagnosis of endocarditis going to be, not today, but 10 years from now.
Correct.
So blood culture negative endocarditis, as all the clinicians in the call this evening know, it's a tough one, man, right?
Yeah.
Because you don't know what you're doing, right?
Right.
At the end of the day, you don't know what you're doing. And you get points for being right and not for style. And
Correct.
so as a result, you end up over-treating these patients many times with toxic medicines, and they just don't do well.
Correct.
So that is an area where, where I do feel that technology will ultimately be able to help.
Correct.
Because it can confuse the issue with facts in terms of helping to identify what you're treating, and therefore how to do a better job at it.
Correct. And I think you're absolutely right in terms of the vision, right? I mean, it might not be realistic to do in every patient right now, but in 10 years, 15 years, we've seen that in so many other areas in medicine of things that were so far from our practice and now is routinely performed. So I think to be able to at least highlight that options in a document now is really important. So Vince, so continue now into the changes in, let's go with the major criteria. And of course, we talk about the techniques as one of the changes. But the other change that I thought was really a smart and a correct one is the surgical evidence. How important is the surgeon's hands, if you will, or eyes, if you will, for things that we already know, for example, cancer. Sometimes being able to detect things that the CT might not have picked. And somehow I think you guys went into that pattern now with the surgical evidence, right?
I think so, Renato, and I agree with you. It's really impossible to replace the ability to directly inspect and touch, handle a sample, and look at it with an experienced eye of a highly experienced surgeon. This was one of the additions that we made was adding a new major criteria, right? So in the past, the major criteria were one of two things. They were either micro or they were imaging. So either positive blood cultures or what have you, or they were, echoes or what have you. So we added a third major criteria, largely due to the input from the cardiothoracic surgeon, who said, there are times when cases, particularly for some of these chronic fastidious endocarditis, like Q fever or Whipple's, or these things that the endocarditis actually is not suspected. And it's not until the surgeon is evaluating the valves and realizes that there's friable structures that look like vegetations, or the tissue is adherent, or just whatever. There's structures that are concerning him or her for the possibility of something else going on. And if in such situations, the diagnosis of endocarditis would be missed entirely if, for instance, the person hadn't done echo beforehand, or didn't send the valve for histopath or for culture, or what, the things that happen in real life. So that was the basis on which we introduced the concept that the surgeon's direct inspection was at least as diagnostic as the presence of a vegetation on an echocardiography.
Right. No, I think that was a really smart decision from the committee, Vince, because especially in the lack of so high quality evidence in this field, I think relying on these criteria is a very accurate thing to do. But along those lines, Vince, we also seen an expansion of the imaging criteria, which I think is also really important. Talking about what's current now, but it's not in 10 years. Let's go back 20 years ago, where we basically only had transthoracic echocardiogram, and TEE was not something that we used to use so commonly in practice. And now we know that TEE became, of course, still the TTE is the standard, but we know that TEEs became almost mandatory in an endocarditis patient, or at least in a suspected endocarditis patients. But then, because it has better sensitivity and might identify better the structures and the lesions in the valves. But you also talk about now incorporating cardiac CT and even PET CTs as other modalities. So tell us a little bit about the rationale, and And of course, maybe the combination might be the perfect way to not miss any potential type of lesion in a suspected endocarditis patient.
Well, I think that's right, Renato. And, in many ways, so there are some things that stayed the same. Echocardiography is still the main diagnostic mechanism or modality for endocarditis. That remains unchanged for a variety of reasons that you cardiologists on the call would know far better than me. So that hasn't changed. What's been added and supplemented to it is the fact that, technology has moved on and that there are these new techniques like PET-CT and like cardiac CT that can provide supplemental information above and beyond echo. And there are some nice studies that show that the use of both really provides better diagnostic and surgical planning than the use of either alone. So for those reasons, and the strong body of evidence in terms, particularly with PET-CT, we included those imaging modalities. I can tell you there was one that the European Society of Cardiology included that we elected not to at this point, and that was SPECT-CT, the SPECT scan, just because it just didn't seem to have enough data, published data out there, and the data that was out there was not as impressive as I would have hoped. So that ultimately was a decision in which we for this round we elected to hold off on SPECT-CT at this time.
Correct. Okay. No, and I think, Vance, you're absolutely right. The regular echo is still the standard, but as far as I can see when I travel all over the world, I mean, TEEs are now pretty commonly performed, and I think they are really good in terms of looking at vegetations and perivalvular leaks. As a matter of fact, better than the cardiac CT for those type of things. But cardiac CTs are better in terms of other things like pseudoaneurysms and abscess, things like that. So again, I think now we are getting to a point where understanding what type of modality is better for what kind of problem, you could always join or combine those modalities, as the studies that you mentioned, where you combine the two modalities and you show that you are better than either alone. And I think it's always reassuring when we see results demonstrating that, which is not always the case. Sometimes it's just increased cost and you don't gain in accuracy or the power of discrimination to make the diagnosis. So I think that the way I'm seeing now, TEE becoming almost like the standard, and CT being there to help, and the PET-CT more for the complex cardiac implants, congenital heart disease, based on the positive predictive value that the PET-CT has. Would you agree with that approach?
Yeah, I think that's right. It's individualized, of course, and there are circumstances in which the answer is clear with a chest wall echo alone, and they need to go to the OR. By the same token, there are circumstances in which there's a lot of confusion, particularly in these complex cases that you've alluded to, in which and for staging and diagnostic purposes, particularly abscess and aneurysms, pseudoaneurysms, and so on. Some of these additional next generation imaging helps. It's interesting in Europe. One of the other areas that we ran into was geographic differences in practice. So, for instance, almost all of the literature for PET-CTs for the indication of endocarditis is coming from Europe. Because in the U.S., it is very, very difficult for me to get a PET-CT, primarily because of insurance, so that the third-party payers are not willing to to pay for the diagnostic approach, and so we don't use it very much. So there's that factor that we had to factor in too.
Correct. Great, Vince. That's great. So I think we went over all the major criteria. So let's talk a little bit about the minor criteria, because there were a few changes in that or in those. And one of the things that I think you guys were spot on, or actually was the predisposed conditions, particularly nowadays, again, going back to what was not common 10, 15 years ago, but now it's another reality. And in 20 years from now, it's going to be completely different. But nowadays, we have a lot of the implantable devices, right. and we have the procedures that can be done also minimally invasively, such as TAVR and mitral clip and other types of procedures that we are doing now in cardiology. So this is the reality now, and all of these were incorporated into the predisposed criteria, correct?
Yeah, that's right. Endovascular devices, cardiac endovascular devices, so valves, prosthetic valves, whether they were implanted transcutaneously or through an open procedure, and endovascular cardiac devices, so pacemakers and defibrillators that are endovascular, of course, were considered to be predisposing conditions as well. And I think, clinically, that's certainly the way I manage them. I suspect that's the way most of us do. And it seemed like that was a factor that probably needed to be folded into be reflected in the current criteria.
Correct. Yeah, no, I think that's right. And again, I think the way we are seeing these procedures and these implantable devices is just growing. It's just growing, right? I mean, we're just seeing more and more people using more indications, and patients getting older, and a larger proportion of elderly. So those things are going to be more and more common, and I think we need to pay attention to that.
Absolutely.
The other thing that is very interesting, and I was very happy to see that you guys have incorporated, because particularly I always have kind of, in my practice, have considered those things minor criteria, which was the splenic and the cerebral abscess. And for some reason, this was not contemplated, or those were not contemplated before. Although when you see a patient and you've seen those cases, you say, oh my gosh, this is aligned with endocarditis, especially, of course, if the case is a suspected endocarditis. But why made you guys change your mind to now finally incorporate those as minor criteria?
Well, Renato, I guess those two, we just looked at it as like, well, they had to get there somewhere, right? They got there somehow. And, they got there the same way that an infarct got there. In fact, they probably started off as an infarct and they just weren't recognized as such. So it really was just the realization that the pathogenesis, the mechanism of disease, was basically the same. It was an embolic event of organisms cascading into a vascular bed and then setting off infection there. So that was the rationale for that. Now I can tell you. Oh, so go ahead. Sorry.
No, go ahead. Sorry.
There was a huge amount of controversy, and it ultimately was taken out because one of the reviewers made a big deal out of it. And that was vertebral osteomyelitis, so spondylodiscitis. And, there was, there, particularly with Staphylococcus aureus, the association of spondylodiscitis and underlying endocarditis is, pretty well recognized. But it's primary, and there are, studies that have made that association, but they're just, I had originally included it. I felt like it needed to be in. We voted for it, and it was voted to be in. It ultimately was taken out in the review stage because, the reviewer correctly pointed out that the association was disproportionately with just one or maybe two organisms, Staph aureus, maybe Enterococcus, and that's it. I don't know if that's going to be the final answer or not, honestly. But we took it out, And I would say that that really underscores one of the things that I think that kept the process moving is that we accepted up front that this was not going to be the final document. In other words, we're not going to wait 20 years.
Correct.
Technology is continuing to accelerate. Diagnostic space, microbiology space, epidemiology, everything's changing. So our goal, my sort of vision with this was to ultimately make this some sort of living document,
Right.
such that it's available online in much the same way that in the HIV space we have, a living document for treatment. For hepatitis C, we have a living document for treatment, and that's kind of how I envisioned this endocarditis criteria. It probably wouldn't be every year because otherwise the researchers couldn't keep up with the versions. But probably every 4 to 5 years, we'd publish updates and make them available on the website. So I think that's sort of the vision of how we're going to do it. And we may end up changing this spondylodiscitis in the next round.
Absolutely. And I think based on what you said, I think was the right decision based on pathophysiology and also biological plausibility, right? So because we don't have high quality evidence, again, a few associations keeping the pathophysiology in mind makes total sense. But I hope that also, Vince, with this document, I think people are going to be motivated. And maybe that's one of the goals of a consensus document, is to people come along, use more standard definitions, and be willing to do more research in that field. And in a way that maybe in 5 years, we have higher quality evidence to maybe change a few of the recommendations that you guys have done so far. And even if that happened before, you can always also do the focused update in a particular area so that people are aware and you can let the change go viral and everybody applying in practice, right?
Yeah, I think so. I think it's important to have a good, healthy dose of humility, because we've created what I feel is sort of the state of the art today.
Correct.
And it may hold true for several years, but things are going to change. I mean, think about, the people on the call here. You think about reading some of these papers that came out when you were a medical student or, 20 years ago. And you're just like, how in the world could these incredibly smart people just make these basic things? This is common knowledge. Everybody knows that. The problem is, yeah, of course, in 2023, it's common knowledge. But in 1973, it was non-knowledge. It wasn't known. Things changed. So I think, one of the advantages I hope this will provide is the ability, to incorporate that and plan for change prospectively.
Correct. No, absolutely, Vince. And the other, just to complete the final change in the minor criteria was the glomerulonephritis, also immunomediated. Was this the same rationale?
It was. It had been in the previous documents, iterations, I think. But the problem was no one knew what it meant. There was no definition for immunomediated. And if you've got a person that you got on vancomycin and gentamicin, and their creatinine goes up,
correct,
it's conceivable that it's immune complex mediated glomerulonephritis. It's also possible that you're doing it to them because you're with these poisons that you're giving them. So, there needs to be some means to try to standardize what constitutes immune complex mediated glomerulonephritis. That's really cool.
Correct. Absolutely. That's great, Vince. Let's move now to treatment. Not much change in treatments, right?
No, in terms of the the diagnostic criteria, that it's really just sort of setting the stage for folks to treat. In terms of where we as a field are going, there's some interesting developments that are worth watching. You know, drug-resistant bacteria is, of course, upon us all over. Some of three areas that are interesting. There are two, I would call it one loss. So one red light, one yellow light, and one green light in terms of new treatments. The green light is a thing called ceftobiprole, and it is a cephalosporin like ceftriaxone, except it has effectiveness against MRSA. And so you have a cephalosporin with MRSA activity. And so I was the overall academic PI on this project, and it's so we did the first phase. It was only the second phase 3 in Staph aureus bacteremia that was ever completed. The first was one for daptomycin in 2006, and then there was this one. But the interesting thing about this trial was that it was double blind. So there was a double-blind design, so we were able to randomize patients with complicated Staph aureus, including right-sided endocarditis, to receive either daptomycin or ceftobiprole, and in a double-blind design.
Correct.
The results were released last fall at ID Week, and we met our primary efficacy endpoint, and it was safe. And, you know, it's a positive study, and it's under late review at a major medical journal that we're crossing our fingers for. So that was the green light. The yellow light is a thing called exebicase, this class of drugs called lysins. So what they've done is they've taken bacteriophages. These are viruses that kill and eat bacteria. So they've taken these bacteriophages and they've isolated the business end, the part of the virus that kills the bacteria. And then they have amplified that product in recombinant technology, and they made a drug out of it. And so the first one was a phase 2, double blind, and it was an adjunct, so you gave standard of care. And it had a significantly better clinical cure rate in the MRSA group of MRSA bacteria and endocarditis compared to standard of care and placebo. It went to phase 3, and the reason I say that it was a yellow light was because in the phase 3 with this product and that design, there was futility analysis declared it was futile, and the study was stopped. There's a lot of discussion about whether it may have to do with the endpoints that were used, which I'm not going to get into in this call, but bottom line is they were using the wrong tool. So there's still some other companies that are interested in those compounds. And then the other sort of option is bacteriophages themselves. Everybody is interested in trying to use bacteriophages to treat patients. There are a lot of case reports that show they're successful, but doing the actual clinical trial that's going to get it approved by the FDA and the EMA is going to be really hard. And I think I'll stop there.
Great. So some new things coming in the pipe, and we might have some other options coming up. So thanks for sharing that. In terms of the prophylaxis, the only thing that I think is aligned with everything we said here is that now we have to expand as well and maybe be a little bit more aggressive for prophylaxis, given the fact that we have more people with implantable device, more people with prosthetic valves and things like that. Is that really what you guys did?
I think that's mainly right. I think you know the number of patients with prosthetic valves are growing. The issue of dental prophylaxis has been going on for decades. We're not going to solve this thing. You know, it's there. Although I will say there is a trial in France that involves many tens of thousands of patients where they are trying to do it. So who knows? They may actually be able to crack the code at the end of the day. In the meantime, the sort of populations are still the same. Prior endocarditis, heart transplant, prosthetic valve, congenital disease with that kind of thing. And so, those are sort of, I think that's kind of where things are.
Correct. Great. So, Vince, we're getting to the end here. I got a question here from one of our attendees here, and Bruno Cesar, and he said he asked the question: do you think that PET-CT should be used as standard imaging modality in discriminating infective endocarditis in prosthetic valves or implantable devices?
Yeah, great question. I think that I'd say that it probably should be used more frequently than we in the United States do use it in that setting, particularly for those scenarios you described. I'm assuming that your question involves valves that have been in for more than 90 days, and I'm going to answer it with that assumption. There's some circumstances where you probably don't need it. If they got positive blood cultures and the echo is positive, I'm not sure that it's helpful. If you've got negative blood cultures and confusion, then I'd say they probably are something that you really need to lean towards. And I will say that personally, I learned a lot from these diagnostic criteria process. One of the things I really learned a lot more than I did before was an appreciation for PET-CT, just because of the opportunity to learn from my European colleagues, the radiologists and the cardiologists that use it day in and day out. So I'm a better doctor, I think, because of that. And I think the answer to your colleague's question is, yeah, when it makes clinical sense, it's probably a good thing to do.
Correct. And you mentioned the 90 days, Vince. Do we have any good evidence of why these 90 days and not 100 or 200?
Well, 90 days is because somebody, sort of did that. I mean, it was the time point that was established, with the 2015 European Society of Cardiology. But why 90 days? Who knows? What we know is that prior to 90 days, for the things that, again, the cardiologist would be very familiar with, things like the type of glue, even the types of valve tissue or the valve or graft tissue itself, you can get false positive results. That's right. All. Yeah.
Correct. Perfect. And Vince, just to finish here, that has been great, and what an honor to have this live with you and clarify so many important points. Is about what you and I know very well, which is the external validation, right? So the criteria, it's out there, people are going to start using. How important is the external validation? And I know you and I are going to talk about potentially doing some validation in some cohorts in Brazil, but I'm sure you are already doing some studies in different parts of the world. Can you just tell us what's going on and what the plan is and how important you think this is?
Yeah, sure. I mean, that's easy. The external validation, honestly, are probably more important than the diagnostic criteria itself. The diagnostic criteria, in my view, is a good idea. I'm biased, of course. I spent the last year and a half working on it, but it's a good idea. That's all. Basically, external validation or not are going to show whether it's a good idea that anyone should care about, and particularly clinically and from the perspective of research. To that end, there's been a real aggressive effort to address to focus on external validation. There are at least 3 that are going in for submission to journal by the end of this week that I know of. And there are one from the Netherlands, one from France, one from Switzerland, one from Sweden, and there's one looking at specificity alone from France. I will show, if there's a couple of minutes, 1 minute, I'll show one more slide because
No, please go ahead.
If you don't mind. This is unpublished data, but
Great.
it's always, this one's, I think, fun. And let me share that. Here we are. So, okay. So this sensitivity and specificity so there have been a number, as I mentioned, of done. So this is one that it's been submitted to ID Week for presentation. This is from the University of Amsterdam, about 600 patients prospectively enrolled. We wanted to use contemporary patients because obviously the diagnostics were contemporary. So enrolled from 2016 to 2021. The tricky part with endocarditis is the gold standard, particularly if they don't go to valve surgery and they don't go to autopsy. How do you really know they have endocarditis? And so what we did was got a panel of international experts in endocarditis, but for the folks from the ISCVID, who reviewed all the cases and ultimately made a decision, and they had to have a consensus of at least two of them, of three reviewing it, and then compared the 2023 Duke-ISCVID criteria to the 2015 European criteria to the modified Duke criteria of 2020. And so these are the data. What you see is that compared to the Duke-ISCVID, the Duke-ISCVID criteria had a significantly higher sensitivity than ESC or MOC in first column there. That was significantly greater without sacrificing specificity, which is in the second column. And so that's encouraging. Now I can tell, and that when you looked at the specific added value, what were the factors that contributed to the benefit in terms of sensitivity, you can see them illustrated here in the red blocks. So you see that changes in the microbiology criteria and changes in the imaging criteria were really the primary contributors, drivers exactly, to this additional sensitivity.
Fascinating. Fascinating data, Vance. I look forward to seeing this in press. But luckily and hopefully, I think this will stimulate more groups to reach out to you and collaborate. As I've been saying for the last years, I think we are in an era of collaborating or perish. It's not more publishing or perish. It's collaborating or perish.
Could not agree with you more. 100%.
Right. Great. So I have two last questions that I really feel I need to ask you, Vince. So sorry, we're a few minutes over. Remo is one of our faculty members at VCRI. He asked a question about what would you recommend for physicians where in their practice only the classic TTE echo is available as the imaging modality?
Yeah, I think you use what you have. And then when you don't know, personally, my approach is to err on the side of caution, particularly as regards to treatment. For things like, does a patient need to go to surgery immediately? A chest wall echo is pretty good at answering if there's hemodynamic failure, and of course, if they've had a stroke, you'll know that because of CT imaging. But if the question is, do I need to treat this person for 6 weeks of antibiotics, and I'm not entirely sure they've got endocarditis, to me, that's a really easy decision. And that's probably the way I would approach it.
Correct. Okay. And the last question from Rinaldo Siciliano, and I, of course, taking advantage of your expertise in molecular microbiology, he asked about the new genetic techniques for microbiological diagnosis. What would be the best technique for the future? Any viable option for blood diagnosis?
Yes. great question. And the answer is yes, that there are currently techniques, diagnostic platforms, including at least one company that's available and functioning, where they can identify pathogen, the etiology of an infection by isolating the DNA from the pathogen in the bloodstream.
Right.
And there are two ways I think we can use that. One is in the setting of culture-negative endocarditis, when you don't know what you're treating, to tell you what to do. The second is when you know what you're doing. Think about, you isolate blood Staph aureus from the blood. You really don't need a $2,000 DNA test to tell you what it is. You grew it from the blood cultures. But you use it in that instance, not when the result is positive. You use it when the result is negative to an individualized duration of antibiotic therapy. Now, that's hypothesis. I haven't done it yet, but that's one of the studies that I'm really interested in trying to pursue.
Right. Fascinating. And maybe in 5 years we'll have the answer for that, and it will be our reality. It's not more just a good idea, as you well said. So Vance, we are at the top of the hour. I really would like to thank you so much for joining, inaugurating our Galen Club, as couldn't be with a better speaker, with a better person, with a better project. It has the potential of impact so many people, and the treatment of a relatively common clinical condition that we face every week, depending on the hospital that you are. We're seeing these cases so commonly. So on behalf of the BCRI and Galen Academy, I would like to really thank you and thanks the audience for watching. And again, a lot of potential collaboration coming on board, and a lot of people that who are here watching today will be able to maybe interact with you through these projects in the future through the BCRI, and that's how we together advance science. So good night, everyone, and thanks for joining.